Hi everyone, welcome. My name is Susila Chapagai. It's great to have you all here. Today, we are diving into something we deal with all the time on the floor, assessing pain for our residents with dementia and delirium. Did you know about 50% of people living with dementia actually suffer from chronic pain? I want to make sure we keep things super open today. This is a safe space, so don't be afraid to ask questions or say times you have struggled with this on the word. We are going to build on what you already know from uni, but focus heavily on practical skills, specifically reading nonverbal cues. So, what is the real hurdle here? Well, if you have probably noticed that residents with advanced dementia cannot always just point and say, it hurts here. If you look at the icons on the slide, dementia causes a severe decline in both cognitive and communicative functions. Because of their confusion and agitation, it's really easy for us to make mistake of their pain for just another behavioral or psychological symptom of their dementia or BPSD. Many nurses actually report feeling they haven't had enough formal training on this. Unfortunately, this means our residents are in danger of silently suffering. They are given sedatives or antipsychotics, but what they really need is just some basic pain relief. Let's talk about how to catch these clinical challenges. It is basically a vicious cycle. If you follow the flowchart on the screen, you can see exactly how this interrelationship works. Pain and delirium often show up together. When the resident is in acute pain, their body gets super stressed, releasing hormones and triggering inflammations that can actually push them straight into delirium. If we miss the sign of pain, the resident just get more and more confused, and treating them becomes so much harder. If we can catch the pain early, we can often stop the delirium from getting worse. Normally, we would just ask a patient to rate their pain from 1 to 10 on numerical rating scale, right? If you can see the icon on the left presenting the self-report method, that is a gold standard. While some patients with mild dementia can still perform self-report, our delirious or severe dementia patient simply cannot. We need to completely shift our mindset away from asking questions and start entirely relying on your observation skills. We have got to look at their body language, listen to their vocalizations, and even get caregiver report to figure out what's going on. This brings us to the PAINAD scale. It has gained massive popularity in evidence-based practice because it is incredibly practical for busy wards and requires minimal training to master. You are essentially breaking your observation down into 5 behavioral indicators, which you can see listed on the slide. How the patient is breathing, the vocalization of sound they make, their facial expressions, their overall body language, and their consolability. You score each of these 5 categories on a straightforward scale from 0 to 2. A 0 means baseline or normal, while a 2 indicates severe and obvious distress like completely rigid body or loud crying. You add up them, and within about a minute, you have a definitive score out of 10. That's a final number is incredibly powerful. It translates a subjective feeling of "I think they're in pain" into reliable clinical metric. This provides a exact objective documentation needed to safely justify and administer analgesia, whether the patient is resting or actively moving. Another excellent evidence-based tool you will see using on the ward is Abbey Pain Scale, APS, which is validated for patients with late-stage dementia or cognitive impairment who cannot verbalize their distress. It operates with slightly bigger scope than PAINAD because it prompts clinician to assess outside of just behavior. On the slide, you can see it evaluates 6 distinct domains. It includes physiological change, such as sudden spike of heart rate, altered blood pressure, diaphoresis, as well as physical changes like presence of skin tear, pressure area, or joint contractures. Because it casts a wider clinical net, recent literature suggests APS can actually be more sensitive at picking up subtle low-intensity pain signals, meaning the pain aid might occasionally underestimate a patient's true discomfort. But just a quick heads up, because we are the ones observing, there is always a chance for a little bit of bias. That's why we try to standardize how we use it across the whole team. No matter which scale you end up using, the name of the game is looking for change in behavior. You really want to zero in on the face. If you look at the slide, we have listed some key facial cues. If you see them doing horizontal mouth strays, parting their lips, and dropping their eyebrows, these are statistically proven red flags for high pain. We are even starting to see new AI apps that we use for facial recognition for this. But your human observation is the core skill. Also, don't forget to chat with their family members. They know the resident best and can tell you when they are acting out of character. Let's step away from theory and look into real case study from the ward. Meet Mrs. Cabell. She is an 84 years old non-verbal patient with advanced Alzheimer's. During routine bed-to-chair transfer, she suddenly became highly combative. While it is easy to dismiss this as standard dementia agitation, applying the PAINAD scale tells a different story. Based on her noisy breathing, crying out during hip movement, or constant grimace, physical rigidity, and being completely inconsolable, she scores 9 out of 10. This definitively indicates severe pain or acute pain, perhaps from undiagnosed fracture or sudden arthritis flare. Our immediate action is to halt the transfer, safely return her to bed, and administer analgesia. After this presentation, your task is to evaluate this exact scenario using Abbey Pain Scale. I want you to calculate your score, interpret your result, and see if your conclusion matches the severe brain crisis identified by our PAINAD assessment. To wrap things up today, just remember that asking for verbal pain score is not going to cut it for our delirious residents. Inadequate assessment can lead to terrible outcomes like prolonged mechanical ventilation in ICU or increased infections. Get comfortable grabbing the PAINAD or ABS tools so we can catch their pain early and get them to the right care. I will be sharing feedback form after the presentation ends. If you can fill it up and give it back to me, I would really appreciate it. Feedback form will help me figure out if the presentation was useful and determine how to improve the session for future reference. Finally, uh, we will have a quick quiz after this presentation to assess your understanding of tools we discussed today. These are the references to the article we use in presentation. Thank you everyone.